This is the speaker link.
Okay.
So participants will be in a separate, different link.
Okay. Okay. Thank you.
Here will only speakers will join, sir. Speaker moderator only.
Morning,
Good
sir.
morning. Good morning. Professor
not audible.
Dayasar, good morning, sir. Kind of presentations, etc. So because we don't have an exam going batch, so that should be kept in mind. Dr. Shiva Prasad and Dr. JP.
I didn't see JP is there, right? Okay.
Yeah, I am here. I am here.
Good morning, JP.
Good morning, sir. Good morning. Morning. I didn't. I am here only. There is some problem with this voice of both of you. It's too long, too low.
Okay.
Is it because of my problem?
You have to increase the audio volume in your laptop.
Yeah, that I had already done. Maybe.
Now also it's feeble only.
And now it's better.
Hello.
Okay.
Hello.
Good morning, sir. Dayasagar, sir. Good morning.
Dayasagar, sir. Good morning. Nothing is mute.
Good morning, Shiva Prasad and Dr. Jayaprakash and
Good morning, sir. Good morning.
I think we will, we're on time. I think we can start.
Yes, sir. So if you're okay, I'll start in 30 seconds, sir. We'll go live in 30 seconds. Five seconds to go. 3, 2, 1. Please start.
Professor Dayasekhar, you want to make some introductory comments, sir? I think you're muted.
No, I think this is a masterclass aimed at helping all the DNB and the DM candidates in the specialty of cardiology. This is basically exposing it to all the different points of view on the same subject at any given point of time. And it will facilitate in improving your knowledge and the clinical skills. With that, I will hand over to Dr. Natarajan, and you can start the proceedings.
Thank you, sir. And I thank both you as well as the CSI for having chosen Amrita Institute of Medical Sciences, Kochi in Kerala to be the presenting center for this nice initiative of the CSI Masterclass aimed at training DM, DNB PGs. And I extend a warm welcome to my very good friends and two of the most respected teachers in our state, as well as in the country, Professor V.L. Jayaprakash, who is a former HOD of cardiology in Kottayam Medical College. And because of his excellent teaching skills, is currently Professor Emeritus in the same medical college in Kottayam, and also the sitting head of the Department of Cardiology, Professor Shiv Prasad. I welcome both of you to this session. And to introduce the presenter, Dr. Marsha is our DM PG who has just finished her first year DM cardiology. We don't have an exam going batch, so she's getting exposed to the nuances of exam-oriented presentations. And we will begin the session. We have a very interesting case, which is commonly kept in the exam as a long case. And we also have some important insights into therapy in this patient and how this patient behaved after the therapy, which also will be very useful from the postgraduate point of view, extending beyond just physical examination. Over to Dr. Marsha.
Thank you, sir. I'll just share my screen.
Maybe they have to give you sharing privileges.
Sharing.
Maybe they are not able to share.
Sorry, just give me a minute.
Sure, take it.
Can't. I am not able to share, sir.
You can request the technical team to help you. Anybody in the technical team is trying to help you, or?
No, sir, I'm not. Is there someone?
You can request Dr. Natarajan to ask the technical people to help you? Do you have access to that technical team?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Okay.
Some issues are there, technical issues?
Yeah, I think
Sir,
he's not able to share her screen.
I don't know how to get the
Are you at the hospital or at your residence?
No, sir. I'm in the hospital, sir.
So you can request any of your colleagues if they can help you.
Yes.
Yes, Marsha. Technical team from where? You're not able to share, is it? Sir, due to some technical reason, she's not able to share her screen.
Mhm. Can she read it at least?
Mm. Let me see if there's a problem technically, because I'll try to share my screen. Let's see if it works.
Yeah.
Is it working?
Right.
Mine is working?
Yeah. It is working.
Okay.
It is working. You can see your slides.
That means it is not a technical problem. Mm. Marsha, you do one thing. You just start by reading your presentation. You have a PowerPoint with you, right?
Is she there?
Yes, sir. Yes, sir. Yes, sir.
You're able to share now?
Sorry.
I was able to share it from my laptop. That means it must be a technical issue. Maybe you can do it from your laptop instead of the hospital system.
So this is the laptop only, sir.
You want to open through mine?
Sir, just a minute. Sir, I will just rejoin, sir. I managed to do it. I'll just rejoin the meeting in a minute.
Okay, okay. So she's able to share now. You are muted.
Sir, is my
Okay.
screen visible, sir?
Yeah, it is visible. Go ahead.
Okay, sir.
Sorry for the delay.
Sorry.
Okay. Go ahead.
Our patient for today is a 50-year-old male. The first time that we have examined him was in July 2022. He is a 50-year-old male residing in Thrissur, Kerala, who presented to us with complaints of dyspnea on exertion, class 2 for the last 1 year. His complaints were a feeling of breathlessness after walking 1 flight of stairs or walking on level ground for 3 to 4 minutes. This was associated with history of easy fatigability also for the last 1 year, and the symptoms were relieved on resting for 1 to 2 minutes. The dyspnea on exertion has progressed to grade 3 since the last 1 month prior to this presentation. There was no history of any associated orthopnea, no history of any associated PND. There was also a history of pedal edema up to bilateral mid-calf for the same duration, not associated with any pain or redness. He noticed that the swelling in the feet progressed through the day, and after sleep, there was only a minimal change in the morning. There was no history of any effort angina or palpitations at this time. He did not notice any abdominal swelling, abdominal distension, or abdominal discomfort. In terms of his past history, he is a known case of an old CVA in 2001 when he had right hemiparesis, which improved, and he has now he has no neurological deficit remaining. He also has bilateral lower limb varicose veins. He has a non-healing ulcer in the left ankle. He was admitted in February of 2021 with history of breathlessness for 1 day associated with 2 episodes of syncope. At this time, at the hospital that he presented to, he was diagnosed to have a clot obstructing his lung blood vessels on the basis of a CT scan that was done at the time. He was then started on thrombolysis for the same. He received about 12 hours, and after which he developed sudden onset of a severe pounding headache. The thrombolysis was stopped prematurely, and he underwent a CT brain, which showed an IC bleed. It was at this time that he was then referred to our institution and underwent decompressive neurosurgery, followed by a prolonged ICU stay with mechanical ventilation. He recovered from this episode and was discharged on appropriate medical management at this time. On examination at this time, this is in July of 2022, our patient is conscious, oriented, sitting comfortably in the chair. He had pedal edema, which was of the pitting.
Marsha, you should stop here. I think we will invite Dr. Professor Shiv Prasad as well as Professor Jay Prakash to let you analyze the history and arrive at some possibilities before you go to the examination. Over to Dr. Jay Prakash and
yeah. I think because we are having a case discussion, let us have some discussion on the history also. Masha, how will you approach this history of this patient who is primarily having a dyspnea, class 2, progress to class 3, fatigability, pedal edema? How will you approach the history?
Yes, sir. The patient's symptoms, including that of dyspnea as well as that of pedal edema, with the past history that he's giving, sir, are symptoms that would probably suggest right heart failure symptoms in this patient, sir. As there is no history of any PND, no history of any orthopnea. The patient doesn't have any other respiratory complaints, no history of a recurrent cough with purulent expectoration, any wheezing. It would suggest probably a right heart involvement in this patient. With regards to the significant past history that he's giving, sir, he's had an old CVA in the past, followed by which he was then also told to have a clot in his lungs. So, sir, something that is predisposing the patient to a right heart failure would be the first differential diagnosis that I would like to keep in mind.
Yeah, let me tell you, the clot in the lungs was diagnosed subsequently well after onset of the dyspnea and fatigability.
No, sir, I'm sorry. The first history that I presented was the history of the present illness. Before that was the past history. So which all these findings were about 1 year prior to the presentation, sir.
So the clot in the lungs was diagnosed 1 year prior to
yes, sir. Yes, sir.
Okay, let me ask you, by far more common, dyspnea means it's a left heart disease. What made you think it is a right heart problem? Because whenever there's a dyspnea in a patient, we tend to think on a left heart disease. So
Yes,
this is
sir.
far more common in left heart disease.
Yes, sir. So one is the association of, he presented to us with severe fatigability, a lot of malaise, the association of pedal edema, which is associated with the breathlessness, and so the absence of orthopnea and PND, which we would have expected to be seen classically in our patient if there was any left heart involvement.
Okay, so the lack of PND and presence of this pedal edema and the history of clot in the lungs made you think it is a right heart disease.
Yes, sir.
And if it's a right heart disease, if you think so, how will you approach further from the history?
One more,
Um,
Prakash, can I
Yeah,
interrupt? Do you have
please.
any picture in the history which actually points that left heart symptoms are unlikely in this patient?
So the absence of orthopnea and PND, sir, there is no.
Exactly. Orthopnea and PND are specific. Actually, PND is a specific usual clinical pointer towards a left heart pathology. So here you said strikingly PND is absent. That is one point you can argue that probably the left heart symptoms are not, left heart pathology is not the one which contributes to her exertional breathlessness. Otherwise, exertional breathlessness, most of the time it is due to a left heart symptom where pulmonary venous congestion is the responsibility, is the reason for exertional breathlessness. Now here you had that point, just to remind you that that also can be added as a point that because of the absence of history of PND and episodes of orthopnea, that you think that left heart symptom is not a big possibility compared to the right heart symptoms. Okay, proceed. Marsha, proceed, please.
Continue, you can continue.
Yes, sir. Okay, sir. Subsequently, the patient continued on regular follow-up with us, and he was started on tablet Xarelto, rivaroxaban 20 mg at night, Riociguat 1 milligram thrice a day, Ditor plus, digoxin, and other supportive medications. He continued on this treatment and was on this treatment when we have seen him in July of 2022. On examination, the patient is conscious, cooperative, oriented to time, place, and person, sitting comfortably. On general examination, he has pedal edema that is present up to the mid-calf, is pitting in nature. There is no pallor, there is no icterus, no clubbing, no cyanosis, no lymphadenopathy. His pulse rate was 92 per minute, regular, good volume, equal on both sides, no special character, no radial or radiofemoral delay, and his peripheral pulses are well felt. He had blood pressure was 100 by 70 millimeters of mercury measured in the right brachial artery in the sitting position. Respiratory rate of 20 per minute, abdominothoracic. His JVP was elevated 8 centimeters of water with prominent V waves. There also was a left leg venous ulcer that was seen near the medial malleolus with healthy granulation tissue. Coming to his systemic examination, his cardiovascular examination on inspection, the apex was visualized in the left fifth intercostal space, seen outside the midclavicular line. There were no abnormal pulsations, dilated veins, scars, or sinuses that were noted. The shape of the chest was normal with the trachea in the midline. On palpation, the apex impulse was felt in the left fifth intercostal space, 1 centimeter outside the midclavicular line. It was an RV type of apical impulse. There was also a parasternal heave, grade 2 by 3 that was felt, and a palpable S2. On auscultation, the first heart sound was normal. The second heart sound was narrowly split. There was a loud P2, an RV S3 was heard, and a pansystolic murmur, grade 2 by 6, was heard at the lower left sternal border, which was increasing on inspiration with no radiation. Other systemic examination, his RS examination, air entry was equal on both sides with normal vesicular breath sounds, and there were no added sounds. PA examination, there was no organomegaly, no hepatomegaly, no significant ascites. Bowel sounds were well heard. CNS examination was also normal.
What is the rhythm? Rhythm of
What will you-
sinus?
Yeah.
Sinus rhythms, regular.
Was there any S4?
No, sir, I was not able to appreciate any S4, only an RV S3, sir.
Okay. Any pulmonary early diastolic murmur?
No, sir.
And you said that the apical impulse is RV. Can you,
Yes.
why do you think that it is an RV type of apical impulse?
So on feeling the apical impulse, sir, it was more of a diffuse apical impulse, not well localized to one intercostal space. It was also felt to be, sir, in continuation with the parasternal heave pulsations that were there.
Was there any lateral retraction?
No, sir.
Okay. Okay, it occurred simultaneously with the left parasternal heave.
Yes, sir.
Okay, these are the ample points to say, but there may be a lateral retraction also in cases of RV apical impulse.
Mm.
Okay. And the parasternal heave, you graded it to be 2/3. Was there any epigastric impulse?
No, sir.
One striking thing which I found, I would have looked carefully for an S4 with this parasternal heave and being in sinus rhythm. I would have expected a prominent S4 and right side tricuspid area.
Mm.
Prakash?
Yeah. Let me ask you, Marsha. So from this clinical findings,
Yes,
what
sir.
is the diagnosis?
So,
Can
patient.
you put these findings for a diagnosis and correlate with the diagnosis?
Yes, sir. This would be. This is a case of isolated right heart failure. Probably secondary to pulmonary artery hypertension. The cause, so the etiology of the pulmonary artery hypertension, sir, anywhere from either primary pulmonary artery hypertension or secondary to the pulmonary thromboembolism. In congestive heart failure, in sinus rhythm, with no features of infective endocarditis.
What is the JVP?
JVP is 8 centimeters of water, sir, with prominent V waves.
Okay,
So
let me
you
ask.
add.
Yeah.
Okay, continue. Yeah, Prakash.
Let me ask you, what are the salient things in this? One, the patient is in right heart failure.
Yes, sir.
What are the points to tell that?
So, and from general examination, an elevated JVP, pedal edema. On CVS examinations, are presence of an RVS3.
RVS3 is there. And some
Yes,
RV dilatation is there. You had an
Yes,
RV which is slightly dilated. It's outside the midclavicular line.
Yes,
It's and so there is RV failure. Now the
Yes,
second thing is that, let me ask you on the clinical findings. You are having a JVP of 8 centimeters. Am I correct?
Yes, sir.
And so obviously the patient is in right heart failure.
Yes, sir.
But your split is very narrow, second sound. What is
Yes,
your
sir.
explanation for that? Usually when right heart failure sets in, you know, the RV may not be able to accommodate further volume during changes in respiration. So the second sound tends to be wide and fixed split or fixed split.
Yes, sir.
Yet still, despite right heart failure, your second sound is closely split.
Yes, sir. Sir, in view of the other findings that I've on examination, sir, such as the parasternal heave, the palpable S2, and the loud P2, sir, the coexistence of a PEH, sir, that is probably moderate to severe PEH, sir, that could explain why there is a narrow split S2.
You mean, are you telling PS? Pulmonary hypertension, PH?
Pulmonary hypertension, sir.
Okay, pulmonary
hypertension.
But still, when the RV fails, I was not expecting a second sound to be closely split even after a PH. If the RV fails, the second sound tends to be slightly wide split. You're having a narrow split. Okay, agreed. There are limitations to the findings and all, I agree.
A good point that Professor Jayaprakash is raising. The split is narrow in pulmonary hypertension when the RV function is preserved. When there is RV dysfunction, the P2 gets delayed because the RV ejection takes longer time. So when when you have RV dysfunction where RVS3, elevated JVP, etc., you don't expect a narrow split. That's an excellent point that he is bringing forth.
Yeah, but I know the limitations in the findings, our limitations in the getting the findings, our oscillatory scales, a lot of limitations. So accepting that you are having RVS3. And next question I would like to ask, you are having a right heart failure. Whether it is due to the TR itself, the right heart as well, it's a primary TR or a secondary TR. You are having I presume the pansystolic murmur, lower less than power, you are thinking it is tricuspid regurgitation. Am I correct?
Yes, sir. Yes, sir.
So how will you approach a tricuspid regurgitation clinically?
So, one would be, sir, the grade of the murmur, sir, it's 2/6. There is no associated thrill to say that it is a primary tricuspid etiology. There is no history of
No,
any.
his question is the patient has significant tricuspid regurgitation. How would you approach it? Well, probably what he is having in mind is hypertensive versus non-hypertensive TR.
Exactly.
Yeah.
Because it's a non-hypertensive
Primary
TR,
versus secondary.
that
Primary
can lead
versus
on to right heart failure. Okay, sir. Sir.
primary versus secondary TR. How do you differentiate clinically?
Primary meaning low pressure TR.
No,
Yeah, so
okay,
what is the cause of the secondary? What is the cause of the secondary? First.
most common cause for secondary TR is
Pulmonary artery
pulmonary
hypertension.
hypertension.
So what is the difficulty? There will be all features of pulmonary hypertension.
Hmm.
So this history or findings, there will be features of pulmonary hypertension like a loud second sound, a closely split second sound, parasternal heave. All the coexisting findings of a pH will be there if it's a secondary TR. Second, from the murmur, what is the point that will help you to decide whether it is a primary or
It's actually truly pansystolic.
Sorry, sir?
Which is truly pansystolic murmur, secondary tricuspid regurgitation or a primary tricuspid regurgitation?
Primary tricuspid regurgitation.
So you have done several echoes, right? A patient with severe TR with no PAH. You just see the Doppler quality versus a patient with a significant PAH and TR. Where do you expect the murmur to be more impressive, longer, whether it is due to hypertension or no hypertension, pulmonary hypertension, I mean?
With pulmonary hypertension.
Usually the secondary causes for TR causes significant duration of murmur and loudness. That is, you're more likely to hear a secondary TR than a primary TR. And primary TR are often short murmurs and they are having a superficial scratchy quality, especially in Epstein's, like situations where you get a primary TR, and also in carcinoid disease, also you get TR, which is not very impressive murmurs. Sometimes you may even miss and it will surprise diagnosis during an echocardiogram. So if you happen to hear a distinct pansystolic murmur in the tricuspid area, of course, with features of pulmonary hypertension, most likely this is due to secondary to pulmonary hypertension, secondary TR. In situations of rheumatic heart disease, also you can hear a primary TR, but often it is associated with the left heart disease and pulmonary hypertension. But there are situations rarely you get primary tricuspid valve involvement and you get a TR, which is not very impressive like this. So your concept that primary TR is going to be loud and pansystolic is not really true. You understand?
Yes, sir.
So let me tell you the findings, how to diagnose a secondary versus primary. One, coexisting features of pH, it is secondary. No features of pH, it is primary. Second, one important finding which we all know is the pitch of the mouth. What will be the pitch in a primary versus secondary?
Dr. Jayaprakash, one small thing I wanted to tell the technical support team. Please, apparently all PGs are having difficulty in logging.
Yeah, most of the PGs. All my PGs have not entered because there is a difficulty in getting into the...
Even my PGs just messaged me on WhatsApp. The tech support team, if possible, can you please rectify that? Because none of the PGs are able to open the link despite registration to the...
Oh. What should we do, Natarajan, sir?
We'll continue. At least let Asha get benefit.
Wait.
We'll... I don't
That's
know.
why Very few participants are there because all my pages, 12 of them tried, they are not able to enter.
There is some problem with the link.
That's right.
The participant link is not working. Technical team is not here.
No, they are.
This is Dr. Dasaga. Just wanted to know whether they are not able to open the Zoom and are they entering the password of this conference or not?
They should be, sir, because consistently, a lot of groups they are messaging to me that they have registered yesterday and they have got the link, but that when they click on the link, it is not working.
Now, click on the link. We'll ask you at the end of it their password, which is CSI 456. I do not know whether they have noticed that.
I will message.
No, that is only the speaker link, sir. This is a speaker link for password. So that is reset.
I think they can try the same thing with their link.
Yeah, the delegate separate link, sir.
Yeah, delegate link is separate, but just in case they don't have that, they can try this method.
Or is the tech support can answer if any delegate has logged in the participant link? Are there any PGs listening to the presentation?
No, sir. Actually, there is some server issue. 5 minutes, it will be directed.
That means
Okay. Server issue.
Okay.
While we are trying to sort out the technical problem, can I ask a few questions, Dr. Natarajan?
Yes.
Sure, sir. Sure, sir.
I just wanted to know what exactly you mean by narrow splitting of the second outcome.
So the normal split of A2 P2 that is heard, sir, which is more on inspiration, is not audible in this patient, sir.
That means you're not able to hear no splitting in the inspiration, but are you able to hear the split in the expiration?
Yes, sir.
Well, that becomes a paradoxical.
You just think about the answer which you said. Think about the answer which Jayashankar sir asked, and I think and then answer. You said split is not heard in systole or inspiration, but you heard it in expiration.
Yes.
Am I right?
Yeah, what she said.
Yes,
Please think about it and answer.
First thing is audible expiratory split in any circumstance is definitely abnormal. So
sir,
I just wanted to know what exactly you had in mind when you have written down as narrow split.
sir, normally in inspiration, we hear splitting of the S2, sir, A2, P2, which is normally not appreciated in expiration. So this splitting in inspiration, sir, was not well appreciated in this patient, was narrow.
What do you mean? If you're not able to appreciate the split, then how can you say it is a split second sound?
Sir, the widening, sir.
You mean to say it is heard, but it is the interval between the two is what? Normally, when do you hear a splitting of the sounds? That the interval has to be at least 35 to 40 milliseconds. So when you say narrow splitting, do you mean that there is only single second out sound or during the inspiration, or what else you have in your mind? So what is your definition of narrow split?
It's not a single S2, sir. It is
because when you see the type of splitting of the second half sound, whether it is normal or paradoxical or wide split, wide and variable and wide and fixed. So in your definition of narrow split, how did you define the narrow split?
Actually, she may be handicapped because this is from an old record. It was done in July of 2022. So she was directly involved in physical examination.
Sure, sure.
She's just going through some provided data for the purpose of a discussion. Maybe, sir, you can enlighten the PGs about what should be called a narrow split.
No, I think this has come for discussion in many conferences. There's nothing like a narrow split. There are a lot of people who are telling that the split. I just wanted to emphasize that the splitting of the second heart sound does not relate to the interval between the A2 and P2. It is applied to the way the second heart sound behaves, in the sense what happens to the A2 and P2 during various phases of respiration. Normally, the split is heard, that means separation of the A2 and P2 occurs normally during inspiration, and it is single in expiration. When we say wide splitting, that means split is heard in both phases of respiration. That is both in inspiration as well as expiration. We say wide and fixed when the interval between the A2 and P2 in inspiration and expiration is almost the same. We say wide and variable when the inspiratory split is wider than the expiratory split. But in both phases, it is split. When we say that during inspiration, there is single second sound, and during expiration, it is split, we say it is a paradoxical split. These are the clinical, classification of the splitting of the second heart sound. So I just wondered what exactly you meant by narrow splitting. Did I make myself clear, madam?
Yes, sir. Yes, sir.
So what did you have in mind when you said narrow splitting? Because here we are calling at the bedside, we are calling the splitting based on the behavior of the second heart sound, not on the interval between A2 and P2.
Maybe what she meant was it is single in expiration and it is split in inspiration, but not to the extent she expected it to be split in inspiration in normal people by her experience.
And that is normal splitting. That is split in inspiration and single in expiration. So that is the reason why I said that in the clinical terms, when we say splitting, we refer to the behavior of the second heart sound, not to the interval between A2 and P2. My second question to you, the candidate, is you have said that JVP is elevated 8 centimeters. 8 centimeters from where, madam?
8 centimeters from the sternal angle, sir.
Are you
It's
still
working.
using the same term, same thing as sternal angle?
Sir, sorry to disturb you. It's working now, sir.
Okay.
Delegate link is working now. Yeah.
Sure. Please go ahead. Please continue that.
Okay, so we finish off the question which you asked and then proceed, which is useful to the candidate.
Yeah.
So 8 centimeters measured from the sternal angle, sir.
I think the modern tendency, modern description of the venous pressure being normal or abnormal has been recently revised. Why were you using sternal angle as a reference point?
So as a marker to the underlying right atrium, sir.
So according to you, the sternal angle corresponds to?
Sir, then we add, sir, to that. You add 5 centimeters.
No. Sternal angle corresponds to what level of the cardiovascular system? At one time, I'll tell you, just to make the story short, at one time, it was said that sternal angle bore a constant relationship to the midpoint of right atrium, irrespective of the position of the patient. That's why it was chosen as a reference point. And we were telling that anything more than 4 centimeters above the sternal angle, we were taking it as venous pressure was elevated. Now, this concept has been revised based on a study using the CT scan of the chest in various positions. And it has found that this assumption of the sternal angle being constant with the midpoint of right atrium does not occur. So the current thinking, even in the textbook of Brownwald, it is written is, you make the patient sit up with his legs hanging at the edge of the bed, and then see whether any pulsations are seen in the internal jugular vein. If there are no pulsations are seen in the internal jugular vein, that is between the two ends of sternum, that means the venous pressure is normal and not elevated. So this is what is written even in the current textbook of cardiology by the Brownwald as well as Hurst and Lowe. So this is the current standard. The reason is that the earlier assumption of sternal angle bearing a constant relationship to the midpoint of right atrium is not really true. Okay.
Yes.
Go ahead.
Yes, sir.
Coming back to this, what do you call hypertensive TR and normotensive TR? I think the point is that why is the murmur of normotensive TR short? Whereas the murmur of hypertensive TR is long pansystolic. Any idea?
No, sir.
Because there is rapid equalization of the pressures between the right ventricle and right atrium. Whereas in a pansystolic murmur, there is a continuous gradient throughout the systole. And usually the normotensive TR, that is a low pitch. So much so that if you are not very careful, you can even miss it during the physical examination. Now coming back to JVP, you never mentioned what is the waveform.
So there are prominent V waves.
No, is there a prominent A wave also?
So I did not appreciate any
You
prominent
did
V
not.
wave.
You did not mention what is the response of the venous column to the inspiration, normal or abnormal?
Normal, sir.
I don't think she
Normal means? What is the
So,
normal?
sir, normally during inspiration there should be a fall, sir.
Or why does it fall?
So because of the negative intrathoracic pressure, sir, that is so the blood from the great veins, including the internal jugular vein, will be pulled into the right side of the heart, sir.
So according to you, when there is increase in the flow, the pressure should fall?
So during inspiration, sir.
No, this is during inspiration. Normally, there is a fall in the jugular venous pressure.
Yes, sir. Yes, sir.
So I'm asking you the reason for that. If there is an
Sir,
increase in the flow, automatically you expect the pressure to rise. But here it is falling.
So the negative intrathoracic pressure, sir, there would be a suction effect on the blood from the great veins, sir.
The suction effect is there. I think you have missed the point in the sense that this negative intrathoracic pressure is transmitted to the intrapericardial structures through a normal pericardial thickness. That is the reason why the intrapericardial structures also stretch. That is the reason why there is a fall in the pressure, even though there is an increase in the flow.
Yes, sir.
Okay, go ahead.
Please so
continue.
can we go to investigation, sir? ECG and
Sure. You ask your moderator.
This was the ECG of our patient in July of 2022 when we have seen him, which shows a sinus rhythm with a heart rate of about 95 per minute with 1 VPC with a PR interval of about 180 milliseconds, QRS axis of 110. There is a significant early transition of the R wave seen in V1, V2, V3. There is also a QR pattern that is noted in V1, suggestive of right ventricular hypertrophy with right axis deviation and RV strain pattern that is seen.
So you think it is a right axis deviation with right ventricular hypertrophy?
Yes, sir, and RV strain and a strain pattern as well.
Do you think there is a QR pattern in V1?
Yes, sir.
Any further elaborations on that? The QR in V1, what are the possibilities?
What are the implications of QR in V1?
Right ventricular hypertrophy, sir. So prominent rightward forces in the right precordial leads.
Does it reflect the extent of elevation of the PA pressure is what they are asking in terms of comparison to the systemic pressure? if you have a QR pattern, what does it suggest? The RV pressure is subsystemic, equal, or suprasystemic? That's what probably they're asking.
So QR pattern would be seen in the suprasystemic RA pressures,
Not RA, RV.
RV pressures.
Okay, so QR pattern can be seen in different ways. One is when the pressure is suprasystemic, you can have a QR pattern. Second, something called as a window effect. When the RA is usually dilated, it can have a picking up of the potentials, and so it can have a QR pattern without a pH or without significant pH. Classically seen in Epstein or in the EMF, and all this can be seen a QR pattern. And thirdly, in some of the myocardial diseases, purely myocardial disease, also QR pattern can be.
One more point which is very useful, especially in cases of permanent embolism, if you get a QR pattern that carries a very adverse prognosis and suggestive of severe significant RV dysfunction in the setting of acute pulmonary embolism. But I don't know whether that can be extrapolated to a chronic thromboembolic pulmonary disease. Pulmonary embolism is not known, but it is a good sign in acute pulmonary embolism.
The ECG was taken subsequently, or this was subsequently? If I ask you, what are the features in an ECG to diagnose an acute pulmonary embolism? Of course, this does not look like an acute pulmonary embolism. What are the features in an acute? Suppose an ECG is put as pulmonary embolism. What are the features in the ECG to tell it's an acute pulmonary embolism?
First, there will be tachycardia.
Yeah, sinus tachycardia.
Features of
Okay.
right sinus tachycardia. So features of right axis deviation,
Right axis
right
deviation.
ventricular strain, RV.
Okay. Then
And in a small subset of population, sir, S1, Q3, T3.
Signature patterns. Yeah, you said something. Yeah.
Sir, in a low proportion of patients, sir, but characteristic S1, Q3, T3, if it is there, so then also points to.
it's not seen in, it's seen only almost in 50% of the people. Not very specific also. S1, Q3 pattern, that is called as Mugin-White sign. Then there can be right atrial enlargement.
Yes, sir.
Any new onset bundle branch like
Bundle
pattern?
branch.
What bundle branch?
Right, sir.
What bundle branch block?
Right bundle branch. New
Right
onset.
bundle branch.
Okay.
And
Now,
some strain pattern and SCT changes
I
also.
don't think that is look at the S waves in V5 and V6. And what is the rotation of the heart here? You said about the right ventricular apex.
Yes, sir. So,
In the horizontal plane, you see that the S waves are seen till the V5 and V6, and they are about, say, 10 millimeters, right, in V6.
yes, sir.
It is due to the clockwise rotation in the frontal plane, in the horizontal plane. So, suggestive of right ventricular enlargement. And what about the P waves? Did you comment about the P? Are they normal, abnormal?
Sir, in V1,
Except in V2, I don't think we can make out significance of P wave here, but in V2, it appears to be the initial part is sharp and there is a sharp decline. But in V1, contrary to what I expected, where I expected a right atrial enlargement, I cannot make out the features of right atrial enlargement. Looks like a normal P there.
yes, sir.
With the descent from the peak of the P to nadir of the P is shallow, it's broad. In cases of right atrial enlargement, what is the finding which you get in the P wave? Right atrial abnormality.
Sir, P pulmonale, sir, tall, sharp P waves, sir, the right atrial component.
What are the features? Pardon me, I didn't hear you.
Sir, P pulmonale, sir. A
What are the
tall,
features?
sir, a tall.
What do you consider as a
P,
tall P?
some more than 0.25 millivolts, sir.
2.5 millimeters deflection. Yes. Then they are peaked. It's not broad. They are peaked.
Yes, sir.
Then
Yes, sir.
one more point in V1. You can have a rapid slant of the biphasic P. You can have a rapid slant from the peak of the P to the nadir of the P in V1, it will be less than 40 milliseconds in cases of right atrial abnormality, whereas in left atrial abnormality, this slant is wider than 40 milliseconds in V1. That is by phasic P in P1, we usually call as P terminal forces and all, right?
Yes.
Okay, proceed.
Coming to our patient's chest X-ray, it shows us cardiomegaly with mild cardiomegaly with an RV type of apex. There is a full pulmonary bay, suggestive of full enlargement of the main pulmonary artery. There is peripheral pruning of the vessels that is seen. But otherwise, lung fields and the costophrenic angles are clear.
Having seen the ECG, which I can say that a QR pattern, suppose we have missed an RBBV, the differential diagnosis which comes in a patient with pulmonary hypertension is a previous pre-existent ASD with PH. You can say partial RBBV. We did not recognize the QR, maybe small initial R we did not recognize, then it could be RSR dash or a QR pattern. And you may also think of ASD as a possibility, the pulmonary hypertension. The chest X-ray, what all findings you consider that is not an ASD?
You are asking about ASD with Eisenmenger or ASD with large flow?
ASD with Eisenmenger here, because you have features of all pulmonary hypertension. What is the saturation which you told at the time initially? Did you mention or
no, but we have a CAT study that was done subsequently, at which point time the
examination, I think it is better to clinical examination better to estimate the saturation also.
Sir, I do not have a saturation at the time.
Okay, so we presume that is normal, maybe 95, 96. Okay.
Yes, sir.
What are the chest X-ray features of ASD with PH? And what all not here in this X-ray to say that is not an ASD? With pulmonary artery hypertension. What all chambers are enlarged in ASD normally?
So the RALA, sir.
RALA and RV, which probably we may not see. Then pulmonary arteries, what will happen in PH due to ASD?
Sir, in the ASD, sir, the left pulmonary artery is seen to
main pulmonary artery, left pulmonary artery, and right pulmonary artery is abnormally dilated. And with pulmonary artery hypertension, there will be peripheral pruning, and you will see the bygone shunt evidence as evidenced by end-on views. End-on chest X-ray. Have you heard of that?
Yes, sir.
So those are things which you look for. Here, what do you see?
So here we see enlarged main pulmonary artery, sir, with peripheral pruning of the vessels.
Okay. Any chamber enlargement? Any great vessel shadow seen? What are the chambers you expect an enlargement in this case?
So the RA and the RV.
Okay. How can you make out RV enlargement in a PAView X-ray?
That itself
In
is
a
a
PAView X-ray,
dark
can you make out
X-ray.
RV enlargement? Or some portions of the RV is only seen? In usual chest X-ray PAView, you see the RV outflow tract if it is enlarged. Otherwise, you may not see it unless you take a lateral view. But you can see the right atrium. What are the criteria which you use in the chest X-ray to say that there is right atrial enlargement?
Sir, right atrium in the vertical lens are exceeding more than 2 intercostal spaces.
Three. And width?
And So width of more than,
one third of the right hemithorax. More than one third of the right hemithorax.
okay, sir.
Okay,
Yes,
understood?
sir. Yes, sir.
Yeah.
Can I ask one question to the candidate? This is
Please,
Dr.
sir. Please, sir.
Sagar. What is the evidence here to say there is pulmonary hypertension? What is your radiological criteria to say that there is pulmonary arterial hypertension? Radiological criteria.
The prominent main pulmonary artery, sir, with the pulmonary bay being full, peripheral pruning of the vessels.
That is
and
not right.
an-
That's not right.
Can you trace the vessels to the periphery?
Can you use the mouse?
Sir, they are about till here.
Yeah,
And
that is not peripheral pruning.
No,
Right.
actually, there is a dilatation of the right descending pulmonary artery is the only reliable sign of a pulmonary arterial hypertension of long standing.
Okay.
But what I see here is there is peribronchial cuffing. If you see the left upper and mid zone, that peribronchial cuffing and upper lobe veins or upper lobe vessels are also more prominent than the right lower lobe vessels. There is some element of pulmonary venous hypertension based on the X-ray.
Yeah.
There is no dilatation of the right descending pulmonary artery.
That is a very striking absence.
Absence. And there is a peribronchial cuffing. If you see the right left mid zone and the left upper zone, surrounding each black shadow, there is a thick white shadow.
Yeah.
So that is peribronchial cuffing. That peribronchial cuffing is synonymous with venous hypertension. Just as the upper lobe vessels are prominent, left upper lobe vessels are prominent in the right lower lobe vessel. So there may be pulmonary arterial hypertension, but there is some pulmonary venous component here. I do not know what is the cause, but probably we will have to see it as we go through. Go ahead to the candidate.
Okay.
the echocardiography that was done at that time, the parasternal long axis view shows us normal sized LV. The LV is D-shaped with the flattening of the interventricular septum seen with a large right ventricle. There is only a trivial AR, no significant MR that is noted. And in the short axis view as well, we see a significantly dilated right ventricle with the flattening of the interventricular septum. The short axis view at the aortic level with the color flow across the tricuspid valve shows us a moderate to severe TR. The gradient measured across the tricuspid regurgitation of about 60 millimeters of mercury, indicative of RVSP of 60, severe PEH, pulmonary velocities of 0.8. There is significant RA and RV dilatation with mild RV dysfunction with an RV basal TDI of 9. This was the pulmonary CT angiogram done for the patient in the month of July 2022. The patient at this point of time was on oral anticoagulation. As we can see, there is thrombus noted in the right pulmonary artery, extending up to the main pulmonary artery. Just for purpose of comparison, I'd like to show the CT pulmonary angiogram of the patient 1 year prior to the presentation in July of 2022. This was during his initial admission during the acute event. As we can see, the thrombus is, there are large filling defects that are seen in the right pulmonary artery and in the main pulmonary artery. One month later, the patient underwent a CAT study, and this was the data that was obtained. As we can see, His saturations in the SVC as well as in the femoral artery are significantly reduced. There are significantly elevated pressures in the right atrium, and the mean pulmonary artery pressure is significantly elevated. His cardiac output is significantly reduced, with the PVRI significantly elevated to 22.15. In view of these findings and in view of the patient,
Asha,
sir,
you wait.
So finally, what is your diagnosis here overall? Let me ask you something on the echo.
yes, sir.
Some discussion on the pH findings. Can you tell some of the pH findings which are seen in this echo, pulmonary hypertension findings?
Yes, sir.
The mode, what are the
sir.
things that you will see when you take an mode in pulmonary hypertension? What are the things? Usually nowadays nobody takes an mode, but in the exam, if it's asked, what is the mode findings in pH? Can you tell some findings? Masha.
Yes, sir.
What will be absent? You may not be very well versed with the mode. Okay.
Yes,
there are some signs in the pulmonary. One is the absence of the airway. You know, there is an airway in the mode. Then what is classically seen is in between the mid-systolic closure of the pulmonary valve can be there, which is called as a flying W sign. Then the slope, that is after the closure of the valve, there is an EF slope that will be reduced. So some findings are there in the mode. What is in 2D? What do you see here?
So one thing that we noted was dilatation. There was a significant dilatation of the main pulmonary artery, the right pulmonary artery, and the left pulmonary artery visualized.
In the ventricle, that will you see in the echo 2D?
Sir, there will be RA-RV dilatation. So the RA basal,
and what will happen?
RA basal, RV basal diameter to the LV basal diameter ratio would be more than 1, sir.
Yeah, if you look at the short axis that was classically seen, the septum was flat or,
Yes,
or towards the LV side, creating what is called as a D-shaped L. So finally, what is the diagnosis after the echo, all the investigations, caths?
Sir, our patient is a case of right heart failure with pulmonary artery with severe pulmonary artery hypertension, secondary to chronic thromboembolic pulmonary artery hypertension, in congestive heart failure, in sinus rhythm, with no features of infective endocarditis.
Your functional classification.
Sir, so if we say in congestive heart failure, sir, functional class 3.
Why there is desaturation of the femoral artery?
So the probable causes could be one, sir, because of the severe pulmonary artery hypertension, sir, whether there is a stretched open PFO.
So stretched open PFO, LV-EDP, LV saturation is not mentioned here.
So LV-EDP is 12, sir. But
No, saturation.
Saturation is not mentioned.
It was not
we
didn't cross to the left side through the PFO. She is only postulating some mechanisms for desaturation in the patient of severe pulmonary hypertension. Any other mechanism?
Sir, because of the reduced cardiac output, sir, the oxygen extraction would be reduced in this patient, sir, which could lead to desaturation.
But that do not explain the desaturation in the femoral artery.
That's correct. It will only cause
increase the arteriovenous oxygen difference.
That's correct. Such a patient will have peripheral cyanosis. The arterial saturation will be nearly normal, and there will be profoundly low SVC saturation. That's what Professor Shiva Prasad is highlighting. Low cardiac output does not cause cyanosis with the desaturation with the systemic arteries. Stretched open PFO is a valid answer.
Another possibility is there must be chronic thromboembolism in the pulmonary artery, and there are a lot of dead spaces in the lung. Alveolar hyperventilation.
Yeah, one more point, as Dasagar Rao told, the LVDP is towards the upper level. You can see it is mentioned as 12.
And the RA pressure is 21 mean. And this is same thing as What was the time interval between the clinical study and this CAT study?
Sir, 1 month,
1 month. So what is the normal RA mean pressure?
4 to 6, sir.
Here it is
21, sir.
mean pressure. What is your definition of mean pressure?
So the
Not able to define or?
no, sir, I'm not able to define.
Okay, it's a time integrated pressure. So it's not only the amplitude of the rise of the pressure, but also the duration to which it is sustained. So you take a time, mean pressure is a time integrated pressure. And that's what finally counts about the perfusion is the mean pressure. Okay, go ahead.
Yes.
The PA pressure, you kept on telling it is severe PAH, severe PAH. Now that you have the data, based on the data what you have about the pressures in various chambers, what level of PAH is this?
Sir, based on the mean pulmonary artery pressure, sir, it would be moderate, sir. More than 50 would be severe.
More than 50. Here it is. What is
Yes.
the mean pressure here?
47, sir.
47. It is not 50. No. But is there a comparison between the right and left? Like PA pressure versus PA mean pressure versus femoral artery mean pressure, or LV or aortic pressure. Is there a comparison? Is it worth doing that? Is comparable pressures is more important, especially in this case, as compared to the absolute values?
Sir, I am not aware, sir.
No, what sir is trying to tell you is you should always compare the PA mean pressure in the light of the systemic mean pressure. If the
Yes.
patient is moribund, and is having systemic hypotension with, let us say, pressure of 80 by 50,
Yeah.
that time you cannot go by the values of 50 being
Absolutely.
to
Yeah.
cause it. So it should be relative. 50 is when things are good, when the patient is not very sick, the systemic pressures are normal. And if more than 50, you should expect to call it severe PAH. But here, you should also compare it. The mean arterial pressure is only 64. The
64.
patient BP is 100. Patient is a sick man with profound
And the
desat.
cardiac output is very low. Cardiac output is one that affects both sides. So right and left. So basically, in a patient with lower cardiac output, it's always preferable that you have a comparable data between the right and left. I think it is important. Okay, go ahead.
Yes.
One more point I would like to tell, of course, mean pressure is more important, but whenever one pressure is high, you have to take that also. For example, if the mean is 47, means it is only moderate range. Whereas if you look at the PA pressure of 72, it is not it is somewhere the borderline area. So you can justify it is severe. Second, as I told, you have to have a comparative this thing with the systemic pressure. So both ways it's likely to be severe. Moreover, the patient had right heart failure, still in right heart failure. So I may accept it is going to the severe PH range. Can you define PH? Any change in the definition which has happened?
From 25, sir, the pH is now defined as a mean pulmonary artery pressure of more than 20.
Yeah.
As the ESC 2022.
Second change also happened was that exercise definition was taken off. Then
Can
what
you
is
tell me the reason why it has been changed from 25 to 20? You should know the reason. You are aware of it or not aware?
No, sir. No, sir. I'm not aware.
Yeah. The CAT study was done in normal people continuously for about, I think, this is a European study where they found that the mean PA pressure in most of the normal people is 14 millimeters of mercury with a standard deviation of 3 millimeters of mercury. So if you add the mean pressure, 14, to two standard deviation, which is 3 plus 3 is 6. So 14 plus 6 is 20, is the maximum mean pressure of the PA, normal. So anything more than that. Having said that, we are not sure what to do with the patients whose mean pressures of the PA is between 20 and 25. I've been telling mean pressure more than 25. We have got data on the drug therapy of pulmonary hypertension. But what to do with 20, 25, nobody seems to know. Go ahead.
And the same thing with the PVR also. Previously, we used to tell the PVR more than 3 is PH. Now, same thing. As I told you, now it has been reduced to 2. So, mean PA pressure more than 20 and PVR more than 2 is considered as PH.
No, but I think these candidates should also know there are 2 more qualifiers for the statement of PAH. One is the cardiac output has to be normal or less. You cannot say if the cardiac output is more, then hyperkinetic PAH is not same as what we are defining as PAH. So one of the important things to remember is that the PA mean pressure of 20 or more than 20, PVR more than 2 with a normal cardiac output or a low cardiac output. If there is a high cardiac output, then you cannot say it is PAH per se, or we cannot say there is pulmonary vascular disease in the true sense of the word. Okay, go ahead.
Wait, one more thing. While you do cath, it is important to note the diastolic pressure gradient and transpulmonary pressure gradient, diastolic pressure gradient and transpulmonary gradient, especially in situations where this is not the case, but where in situations you are finding it difficult to say it is hyperkinetic obstructive obliterative pulmonary artery disease. That is also given as the value in the cath study. Here it is not important. We know that this obstructive pulmonary artery disease. So a value more than 7 is considered as demarcating between the two. Okay.
Meaning a higher transpulmonary gradient means it is a pre-capillary pulmonary hypertension, where the PA mean pressure is substantially higher than the PA wedge pressure. That's what Professor Shivaprasad is trying to tell.
So it seems to be high because if you look, the PA mean is 47. The LVEP is 12.
Significantly elevated.
Very high, 65. Value has come up 35 here.
Very high.
Right. Proceed. Continue.
The patient, in view of his persistent symptoms and in view on optimal medications, he underwent a bilateral pulmonary thromboendarterectomy in October of 2022. During surgery, it was noted that there was extensive wall thickening extending from the branch PAs into the segmental PAs bilaterally. There was a laminated clot present in the right pulmonary artery. His baseline pulmonary artery pressures were 86 and 38, arterial BP of 126/67, CVP of 16, cardiac output 3.2, cardiac index of 2, and a PVR of 1250. An endarterectomy was done from the distal right pulmonary artery into the segmental PA branches of the upper and lower lobes, and from the distal left pulmonary artery into the segmental branches of the upper and lower lobes. After the surgery, as we can see, the pulmonary artery pressures improved to 47 and 16. There was an improvement in the CVP. There was a decrease to 9. The PVR decreased to 346. And the cardiac output and cardiac index remained about the same. The patient continued to follow up with us regularly, and he was last seen in May of 2023. Now the patient is symptomatically much better in functional class 1. He has no complaints of exertional dyspnea. The pedal edema has subsided, and on examination, he has a pulse rate of 80 per minute, regular, blood pressure of 120/80. JVP is now normal. The P2 is normal and chest is clear. He continues on medical management, maintaining an INR in the therapeutic range on tablet warfarin 3 mg and 4 mg. As this is his ECG at his last follow-up in May of 2023. As we can see, the RV forces, the right axis deviation, and the RV strain, as was noted in the earlier ECG, has improved following the patient's surgery. And there are no significant features of RV strain or RV hypertrophy that is noted in this ECG.
The S waves in V5, V6 have significantly become lesser.
Decreased.
The RV V1 has become much lesser.
Very gratifying result.
and the lead one was completely negative. Whereas you can see here, now it has become kind of isoelectric. The axis is around plus 90 here. That was around 115.
100.
Significant ECG markers to tell that this patient's PA pressures have significantly come down and the RVH has regressed. Yeah.
You have the echo, follow-up echo is there?
Yes, sir.
Okay.
Yeah.
Let us see the X-ray. Let us see the X-ray.
This was the X-ray at his follow-up. As we can see, there is so the pulmonary bay appears to be a little bit more, has appeared to regress as compared to the earlier X-ray. The apex as well, so the prominent RV apex. So there's probably an improvement in the RV size also following the thromboendarterectomy. There is so the peribronchial cuffing that we spoke of earlier. So minimally, does it persist?
But the vascularity has definitely improved. The pulmonary arterial vascularity has definitely improved.
Vascularity is improved. The right pulmonary artery has grown up. Probably you removed that clot from the pulmonary artery there, and it improved the pulmonary arterial blood flow on the right side. And also on the left side, in the lower aspect, there is increase in the pulmonary flow. And overall, the X-ray shows good improvement in the pulmonary artery hypertensive features, which we made out in the previous X-ray. Now, can right-sided disease cause left elevation of the left ventricular pressures? Diastolic. Because this patient had a significant right-sided hypertensive features, and you had on the X-rays there, Shankar sir was talking about peribronchial cuffing and suggesting that the left ventricular pressures are going to diastolic pressures are high. Can you think of any reason why, without having a left ventricular disease or left-sided heart disease, can the right-sided heart disease itself produce these phenomena?
What is that effect called?
Sorry, sir.
Well, there is a named term for that. When there is elevation of left-sided pressures, the intraventricular septum goes to the right side. You saw a D-shaped septum in the echo. So high RV pressures will bow the septum towards the left side. So what will happen to the left-sided pressures, and what is that effect called? And that is one of the proposed mechanisms of effort intolerance and dyspnea in patients with right-sided disease.
The interventricular dependence is exaggerated.
That is right. Ventricular interdependence is one of the reasons for that. But other thing is Bernheim.
Reversed Bernheim effect.
Of course, a lot of theoretical things, but we see also when right heart is involved, the left heart also suffers and gets some ADP elevation. A lot of mechanisms, as already told, one is the pericardial constraint effect is there. You know, the pericardium constraints both.
Pericardial constraint.
So whatever which is dysfunction happens to RV, the LV has to share it so that the LVDP gets elevated. Second, what you had told, the reverse Bernheim effect, where the septum bulges to the IVS goes to the left side, or bulges to the left side, and we have the exaggerated ventricular interdependency. And then we have what they called as a syncytial effect is also there. See, when the RV cries, the LV also shares it. Of course, the X-ray has also shown there is a significant improvement in the picture. Was a coronary angiogram done before the?
Yes, it was normal.
It was normal. Can you go to the echo and show that?
Yes, sir. This is, sir, I have the images, sir. This is just a tabulated column of all the patient's follow-up echoes prior to his surgery and after that. And as we can see, the TR has improved. There's only a trivial to mild TR, with the RBSP decreasing from maximum of 75 to 27. The RV function has also improved. And the diameters, the measurements of the main pulmonary artery, left pulmonary artery, and RPA have also shown an improvement. So his last echo, coming to the images, the parasternal long axis view, showing us an improvement in the size of the LV, in the RV. There is a regression in the enlargement. The D-shaped LV that we were seeing earlier is now normalized. The short axis view again showing us the pulmonary artery size has improved. This is the 4-chamber view. There is no significant TR that is now noted. And the size of the RA and the RV has also improved as compared to his previous echoes. He now continues on regular follow-up on the following medication, maintaining INR in the therapeutic range.
Just wanted to ask you, why did you change the anticoagulant from rivaroxaban to warfarin?
Sir, this patient was actually evaluated for any other cause of any prothrombotic state, but all his evaluation was negative.
So, but then why did you change it from rivaroxaban, which is supposed to have a lot of benefits in terms of not getting any PTI not done, less incidence of intracranial bleeding, and equally effective according to many studies. So my question to you is, why did you change it? Anything else did you have in mind? Or tell me the conditions in which you would like to use a vitamin K antagonist instead of NOACs in clinical situations.
Keeping this patient aside, so we prevent vitamin K antagonists as compared to NOACs in rheumatic heart disease, in prosthetic valves and metallic prosthetic valve patients.
And
Any other situations?
other situations? What is Apla syndrome?
Antiphospholipid antibody syndrome, sir.
There also you try to use mostly vitamin K antagonists. Okay. Any other conditions in which you would like to use vitamin K antagonists? Common condition rather. If there's an underlying kidney disease, which one would you like to prefer?
The vitamin K antagonist.
Yeah. So basically, most of these NOACs are excreted by the kidney, basically by dabigatran, maximum extent, minimally with Eliquis or the. So basically, if there's a kidney disease, we'd like to use a vitamin K antagonist. Why are they called DOACs? There is a name called NOAC, DOAC. What is the full form of DOAC? Direct acting oral anticoagulants. So what exactly you mean by direct acting?
So they are direct 10E, factor 10E inhibitors. So for dabigatran, which is a direct thrombin inhibitor.
So how does it differ from the heparin action? Heparin is also anti-2. The reason is heparin requires a cofactor, antithrombin 3, whereas this dabigatran does not require any cofactors. That is the reason why they are called DOACs. They don't require any cofactors for its complete effect. Whereas this heparin and low multiprovate heparins, all these things require a cofactor. But by and large, I just wondered why you changed it from an NOAC to a vitamin K antagonist in a patient where, according to you, there was no prothrombotic condition existing in that patient. So why did you? So I'm just wondering why you changed it.
Actually, by the current guidelines, patients with chronic thromboembolic pulmonary hypertension, especially after pulmonary thromboendarterectomy, is a class 1 indication for vitamin K antagonist in preference to the DOACs.
Okay.
Any
study is there? Any study is there?
Sir, I cannot recall a study, but according to the guidelines, it is clearly mentioned that this is the preferred drug.
Okay, I think I think we have finished just at the right time.
Is that the current drugs and is he on Riosigat?
Sir, at present, no, but prior to his surgery, he was on Riosigot.
He has only a mild pulmonary hypertension now.
Yes, sir.
But
Now it is
trials have
normalized.
shown that chest trials have shown that this drug is going to be beneficial in this group of patients
Even
with
after,
pulmonary hypertension. But
is it even
should
after
we
surgery?
give or not?
No, right now, is there an indication? The peer
No,
pressure is
pressures
normalized.
are very low.
For the
normal-
peer pressures are normalized.
normalized. But he has two things which we actually did not mention. He has significant varicosities in the lower down, and there is chance of get him into this. But we are giving warfarin that will take care of. But he has a problem with the non-healing ulcer down there. Huh? That is healed.
So it's healing, sir. It's healthy granulation tissue at the last follow-up.
You thought it's a venous ulcer.
Yes, sir.
What is the reason for adding echosprin?
That is also in the current guidelines. Like in prosthetic heart valves, in addition to like in mechanical prosthetic heart valves, this is also one indication where it is recommended because you have denuded the endothelium in the pulmonary artery during the surgery. So it is kind of recommended along with VKA.
Because generally, we don't use aspirin on the right-sided events or what do we call right-sided vascular pathologies. So this is the guideline now. This is
Yes, the surgeons have quoted
This
some
I have
guidelines.
seen, and surgeons here in Toronto Medical College also they use after endarterectomy they use both warfarin and cusprin together. Maybe that get like even after pulmonary endarterectomy.
That's correct. Maybe platelets also play a role in recurrence of.
Mhm. Okay.
Okay.
Oh,
So it was a very good presentation and with educative. I congratulate you for present this case wonderfully. Natarajan sir
Thank you,
for giving us a very good case for discussion. And Shankar sir has given large of inputs which we also learned from you, sir. Thank you.
Once again, I thank you, Narayan sir, and the whole team, there, Sagar Rao sir, and all. And it was a very nice case presented, and the case was very educative also. Thank you all. In fact, I didn't have a much belief in this thromboembolectomy initially, seeing the initial, but we are having a large series of cases now. And I'm really impressed with the results of the patients and how I have had a lot of patients being followed up after pulmonary thromboembectomy. Doing extremely well, extremely well.
What is the mortality in this at your center?
Yeah,
So-
initially it was high, sir. That is why I thought it was around 30%, 40% was the mortality initially. So in the
Yeah.
initial cases, I was unhappy, but now the mortality has come down to negligible amounts. Exact mortality, I don't know, but now the mortality
Yeah.
has come in
I-
single digits. Now it is maybe less than.
I have taken it, but in our place it is around 11% or so mortality.
Mhm.
They are very sick patients.
Yeah.
but with
I
growing,
think Dr. Natarajan has got a talk to give.
is it necessary, sir? We have had such a good discussion. Superb discussion. Most of the points have been covered. I have a short presentation on.
Yeah, I think we still have time, about half an hour before we close. The time is from 11 o'clock to 1 p.m. So if you have got the slides up there.
Marsha, you can stop sharing. Marsha, can you stop sharing? I think she has. Okay, fine. Are you able to see my screen, sir? My
Yeah.
bandwidth,
Yes, sir.
bandwidth is not good.
Very much.
Anyway, pardon me if the audio is not great. So we had an excellent discussion as both the moderators, Professor Jayaprakash as well as Professor Shiv Prasad said, Professor Rao has significantly contributed and all of us have benefited from the interactions. Marsha did a good presentation and most of the points have been very well covered. Now that some PGs had some logging issues in the beginning, and this will probably be a summary of what has already been discussed. I just made some few slides to highlight the importance of right heart failure, particularly with a view towards the exam going candidates. So the causes of right heart failure, we'll go through a few points here. The causes of right heart failure, we will have an emphasis on pulmonary arterial hypertension causing right heart failure because this patient belongs to that particular category. The various hemodynamic subsets of PAH, the clinical classification of PAH, symptoms, signs, routine investigations, risk stratification, and treatment. With this idea in mind, we'll just spend about 15 minutes. Right heart failure can be secondary to left heart failure. In fact, that is the commonest cause of right heart failure. Somebody with cardiomyopathy or mitral regurgitation or mitral stenosis, they can have right heart failure consequent to the left heart failure. That is something to be kept in mind. Then there is an entity called, which is primarily a right ventricular failure, where the left heart is normal, like this patient that we discussed now. And the third condition which can cause features of right heart failure, meaning systemic venous congestion, elevated JVP, ascites, hepatomegaly, pedal edema, where there is no RV failure, but there can be impaired RV filling, typically constrictive pericarditis. When you discuss about primary RV failure, it can be due to chronic pressure overload. We saw the typical case example that we discussed now. Pulmonary arterial hypertension, which can be primary pulmonary hypertension or idiopathic pulmonary hypertension. It can be various secondary causes of pulmonary hypertension due to lung diseases, that is called cor pulmonale, connective tissue disorder, Eisenmenger's, and of course, CTEPH, which we saw a prototype case example. So these are all chronic pressure overload situations, and of course, severe outflow obstructions like pulmonary stenosis and RVOT obstruction also causes chronic pressure overload, which can consequently cause right ventricular failure. The other cause of right ventricular failure is chronic volume overload, pre-tricuspid shunts of long duration, valvular regurgitation like pulmonary regurgitation, tricuspid regurgitation, cause chronic volume overload of the right ventricle, which can also result in RV failure during long term. The other thing is intrinsic right ventricular myocardial disease. There is no pressure overload, there is no volume overload. The RV myocardium is intrinsically diseased. In this category, you have RV ischemia, RV myocardial infarction, infiltrative diseases like amyloidosis, sarcoidosis, genetically mediated conditions like arrhythmogenic right ventricular cardiomyopathy, right ventricular endomyocardial fibrosis, and microvascular disease. These all can cause RV dysfunction due to intrinsic RV abnormality. So all these can cause RV failure and right heart failure. Impaired right ventricular filling is typically caused by conditions like chronic constrictive pericarditis and inflow obstructions like tricuspid stenosis. So these are some of the broad causes of right heart failure. And these patients will present typically with low output state, effort intolerance. In very advanced cases, there can be syncope. Syncope is a very bad sign in this condition. The hallmark physical findings in this condition is systemic venous congestion, elevated jugular venous pressure, hepatomegaly, pulsatile liver, ascites, pedal edema, venous engorgement, varicosities, hyperpigmentation of the ankle. These are all typical features of this particular entity. And now that we discussed a case of pulmonary hypertension, we'll focus a little bit towards specific aspects about pulmonary hypertension. The various hemodynamic subsets of pulmonary hypertension has already been alluded during the course of the discussion that we had. The mean pulmonary artery pressure, if it is more than 20, for reasons already mentioned, qualifies to be called as pulmonary hypertension. In pre-capillary pulmonary hypertension, the mean pressure is more than 20, but the pulmonary artery wedge pressure is equal to or less than 15, and the PVR should be more than 2 Wood units. There will be a transpulmonary gradient. That is very typical of pre-capillary pulmonary hypertension. Isolated post-capillary pulmonary hypertension, again, mean pressure, any pulmonary hypertension, the mean pressure should be more than 20. But in contrast to this, the pulmonary artery wedge pressure is more than 15. And typically, the pulmonary vascular resistance is not very high. In combined post-capillary pulmonary hypertension, you have a mean pulmonary artery pressure of more than 20, pulmonary artery wedge pressure also of more than 15, but the pulmonary vascular resistance is high. When this happens, you should suspect a combined problem, both pre-capillary as well as post-capillary components. Clinical classification, the European Society of Cardiology and has clearly grouped pulmonary hypertension into 5 groups. Group 1 is pulmonary arterial hypertension, idiopathic, heritable, drugs, toxins, associated with collagen vascular disease, portal hypertension, pulmonary veno-occlusive disease, persistent pulmonary hypertension of the newborn. All this comes under the Group 1 pulmonary arterial hypertension. Group 2 is pulmonary hypertension associated with left heart disease. In fact, this is the commonest cause of pulmonary hypertension, both with reduced ejection fraction as well as with preserved ejection fraction, not to forget valvular heart disease on the left side. Group 3 is pulmonary hypertension consequent to lung diseases, typically called cor pulmonale, obstructive lung disease, emphysema, restrictive lung disease, mixed restrictive and obstructive pattern, hypoventilation syndromes, high altitude, chronic exposure to high altitude, and developmental lung diseases. All these, the pulmonary hypertension is the result of a pulmonary problem. That is Group 3. Group 4 is what we discussed, what Dr. Marsha presented. Pulmonary hypertension associated with pulmonary artery obstructions, typically chronic thromboembolic pulmonary hypertension. That is what we discussed in that case. Group 5 is unclear or multifactorial mechanisms like hematological disorders, systemic conditions, metabolic disorders, chronic renal failure with or without hemodialysis, pulmonary tumor thrombotic microangiopathy, fibrosing mediastinitis. All this comes under Group 5. And the prevalence is about 1% of the global population. And in proportion to the elevation of mean pulmonary artery pressure and pulmonary vascular resistance, they have a significant impact on mortality during follow-up. This we have already seen the clinical classification. And I wanted to highlight the fact that the commonest problem is PAH associated with left heart disease, that is Group 2 and Group 3. PAH consequent to lung disease. So Group 2 and Group 3 are the commonest causes. But the worst to have is Group 1, though unfortunately it is rare. That is the idiopathic pulmonary hypertension, etc. Group 4 is a treatable condition. A typical example is chronic thromboembolic pulmonary hypertension. It is eminently treatable by surgical pulmonary thromboendarterectomy, as was shown in the case example. Symptoms in pulmonary hypertension. The early symptoms are dyspnea, fatigue, pendopnea, palpitation, hemoptysis, exercise-induced abdominal distension, nausea, weight gain due to fluid retention, and syncope. These are very important things. And exertional chest pain can be due to dynamic compression of the left pulmonary artery by the grossly dilated main pulmonary artery. That can be a cause for exertional chest pain. Hoarseness of voice, shortness of breath, all these can be very late symptoms. Syncope has a very bad prognostic marker as a symptom in patients with severe pulmonary hypertension. These are some of the commonest questions that are asked in the exam. Causes of dyspnea in patients with right heart failure. We discussed this during the case. Low cardiac output, reduced systemic perfusion of the respiratory muscles can cause a feeling of dyspnea. Hypoxemia due to various mechanisms also can cause dyspnea. Reversed Bernheim effect we have already discussed. Associated pleural effusion. And as Professor Jayaprakash told during the course of his discussion, the RV and the LV work as a functional syncytium, as a team. They may not be dissociated. So RV diseases also can cause elevation of LV pressures and effort intolerance. So these are some of the textbook reasons for why a person with an isolated right heart failure has effort intolerance in the form of dyspnea. Clinical signs, the signs of pulmonary hypertension, the clinical signs can be due to the signs of PAH itself, signs of RV backward failure, like, for example, elevated JVP, hepatomegaly, pedal edema, signs of right ventricular forward failure, and signs which point to the cause of the pulmonary hypertension. You can go through that 2022 European Society of Cardiology consensus statement on pulmonary hypertension. It gives you all these details. Another important question that is asked in the exam is, why do you have cyanosis in pulmonary hypertension, which was also briefly discussed during this case. Oftentimes, because of the patient is very moribund, very sick patient, low cardiac output, it causes peripheral cyanosis. The extremities are cool in this case. And of course, you can also have central cyanosis, as was shown in Dr. Marsha's case. Peripheral cyanosis accompanies right ventricular failure, low cardiac output, extremities are cold, and there is poor capillary refill. Central cyanosis, the possible mechanisms could be a stretched open PFO due to very high RA pressure, pulmonary arteriovenous channels with right-left shunting, which can be due to neogenesis or activated dormant channels opening up. Associated lung conditions, for example, if there's a consolidation, it causes a right-left shunt because there is perfusion, but there is no ventilation. So there will not be ventilation, but there will be perfusion causing a right-left shunt. It's important to know that the foramen ovale is anatomically patent, but not functionally patent in 20% of normal population. It can become functionally patent when exposed to very high RA pressures. So it's 20%, it is anatomically patent, but not functional. These can open up when there is severe elevation of RA pressures, as was shown in this particular case example. Investigations in PAH, the typical ECG findings have already been said. One of the important things which is quite though non-specific, if you have a prolonged QT interval in the absence of other causes like hypokalemia, has a very poor prognostic marker in patients with pulmonary hypertension. All the other signs were already covered during our discussion. This is the typical example. It's almost similar to the patient that Marsha presented. The radiological signs also have been described already. We have had the discussion. This is a typical example of a grossly dilated pulmonary artery, RV type of apex, and peripheral pruning, which are hallmarks of pulmonary hypertension in terms of chest X-ray findings. The echo findings have already been discussed in detail, so I won't go through the details. You can refer this literature, but echo forms a very important integral part of the evaluation of patients with pulmonary hypertension. Cardiac catheterization confirms the diagnosis, classifies the condition as pre-capillary, post-capillary, or mixed varieties, depending on the PVR, the mean pulmonary artery pressure, and the transpulmonary gradient. And of course, very important to know that during catheterization, we do what is called the acute vasodilator test or the vasoreactivity test by inhaled nitric oxide. Or in our center, we have done a study and shown that intravenous sildenafil also can be used as an alternative to nitric oxide, which may be important in places with resource constraints. So if a person's PA pressures come down, if the mean PA pressure comes down by a prescribed value, we call it as a vasoreactive pulmonary hypertension. And these are patients who respond reasonably well to long-term calcium blocker therapy like amlodipine, nifedipine, so on and so forth. So the vasoreactive test is a very important component of hemodynamic assessment because it has got a therapeutic impact as well. This is a typical example. I just wanted to show this video. This is given to me by my pediatric cardiology colleague, Dr. Shine, who has a specific interest in pulmonary hypertension. You can see this on the left side. This is the baseline. The blue is the systemic pressure and the white is the pulmonary artery pressure. As nitric oxide is being given, you can see a dramatic fall in the PA pressures. You can see that there is a dramatic fall. So this is a typical example of a vasoreactive pulmonary hypertension. And this is a patient who will very significantly improve with drugs like calcium channel blockers. So therapeutic strategies is based on the disease category. For example, if you have a patient with the group 1 pulmonary arterial hypertension, medical therapy is with drugs used in pulmonary hypertension, calcium channel blockers in those who are having vasoreactivity as shown in the cath lab. PAH drugs can be endothelin antagonists, phosphodiesterase inhibitor, and of course, in refractory cases, lung transplantation. Group 2, PAH associated with left heart disease. Obviously, you have to treat the left heart condition. And patients are refractory, you can give drugs used in pulmonary hypertension. Pulmonary hypertension associated with lung disease, COPD, cor pulmonale, that is group 3. You have to treat the primary lung problem. And in severe pulmonary hypertension patients, where the lung problem is only partially treatable or non-treatable, you can give the drugs which are specific to pulmonary arterial hypertension. Pulmonary hypertension associated with pulmonary artery obstruction, that is group 4. We discussed that particular case. surgical therapy. There is a role for balloon pulmonary angioplasty in proximal obstructions, and of course, medical therapy in refractory cases. And the group 5, unclear or multifactorial mechanisms, optimize treatment of the underlying disease. And of course, there's a potential role for drugs in pulmonary, drugs used specifically for pulmonary arterial hypertension. Risk stratification, it's important to understand that risk stratification is a very important integral part when you approach a patient with pulmonary arterial hypertension. It is classified as low risk, intermediate risk, and high risk, with a 1-year mortality of less than 5% in the low risk category, 5 to 20% in the intermediate risk category, and a very high mortality of more than 20% in 1 year in very high risk category. So that is based on signs of right heart failure, syncope, WHO functional classification. 6-minute walk test has an important prognostic role. You see here, more than 440 meters in 6 minutes, low risk. 165 to 440, intermediate. Less than 165, high risk. So 6-minute walk test has a very important role. When you have access to cardiopulmonary exercise testing, these are some of the important parameters to differentiate or risk stratify the patient. Biomarkers, NT-proBNP and BNP have a very potential role in risk stratification. You can see the cutoff values of both BNP as well as NT-proBNP. In our center, we subject all our patients after the baseline evaluation to both a 6-minute walk test and biomarker for risk stratifying the patient into intermediate, low, and high risk. Of course, echocardiography, MRI, hemodynamic parameters also have a role in risk stratification. So I will conclude by saying that the diagnostic approach to a patient with pulmonary hypertension is mainly focused with 2 main objectives in mind. The primary goal is to raise clinical suspicion, early clinical suspicion of pulmonary hypertension, and ensure a fast-track referral of these patients with a high likelihood of PAH, CTE, PAH, and other forms of severe PAH, because a focused tertiary care center, which specializes in the management of pulmonary hypertension, is more geared to giving the pulmonary arterial hypertension drugs, to do hemodynamic assessment in a safe manner, demonstrate vasoreactivity, give calcium channel blockers, and CTPH is a reversible cause of pulmonary hypertension. So that is the primary goal, early recognition and early referral. Not wait for the patient to become very sick. Professor Shiva Prasad was telling about high mortality in pulmonary thromboendarterectomy is because we actually postponed the surgery to very late stages. The patient is so sick that the mortality becomes higher. You don't have to wait for the patient to become so sick to subject them to reversible conditions like CTE-PH by surgery. The second objective is to identify underlying diseases, especially left heart disease in group 2 and lung diseases in group 3, as well as comorbidities, to ensure proper classification, risk assessment, and appropriate treatment. I'll stop here, and I once again thank CSI for giving Amrita Institute of Medical Sciences an opportunity to be part of this masterclass session, which is a good national CSI initiative to help our exam-going PGs to get sensitized to how they are getting these cases and how they are likely to face the exam, which will help in the long way. I thank Professor Dayasar Rao for having invited us to be part and for his valuable inputs, and to my good friends and senior teachers in Kerala, Professor Jayaprakash, as well as Professor Shiva Prasad, for having participated and given their valuable inputs towards postgraduate education. Thank you very much.
Thank you, sir. Thank you.
Yes, sir. Thank you.
Thank you, Dr. Natarajan and your group for participating in this wonderful case discussion. It has been very useful, I'm sure, to many of the candidates who are participating in this symposium. I hope it will be of not only useful for your examination, but even in the practical management of the patients with pulmonary arterial hypertension. It's not an uncommon disease. If you are alert to it, you can pick up a lot of patients. But I think a good guidelines directed risk stratification, appropriate medication, and sending them at the for surgery in appropriate cases like a group 4 pulmonary thromboembolism for surgery certainly goes a long way in the proper approach to the therapy of the disease. Thank you once again to all the participants for your participation and enlightening and sharing the knowledge with other candidates. Thank you once again.
Thank you very much, sir.
Thank you.
Thank you.
Bye. Bye. Yeah.